All right, good morning, everybody. Welcome to Medical Grand Rounds. Before we begin, I would like to respectfully acknowledge that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. So excited to present one in the series of our research rounds. And so for introductions, I'm going to ask one of our co-associate chairs for research, Gopi Satendra, to introduce our speaker.
Thank you, Mom. Good morning, everyone. So it's my great pleasure to introduce our speaker today. But I just want to sort of explain why we're doing it in this format. So one of the things we wanted to do with our research grand rounds was provide a platform for some of our newer faculty who just started within the year to provide their research in order to engage other faculty members for collaborative research. So that's what we're doing today with this research grand round. So at the end of it, please reach out to our guest speaker today, for any sort of collaborative research, or if you're interested in doing work with them. So it's really a platform to feature our new faculty and what they're doing in order to show it to all of our faculty members here. So with that said, I'm very pleased to announce Dr. Arnav Agarwal, who is an assistant professor and early career clinician scientist here in the Division of General Internal Medicine. He completed his medical training and internal medicine residency at the University of Toronto and his clinical fellowship in general internal medicine at McMaster University. His research, as he'll be talking about today, revolves around systemic reviews and meta-analysis and trustworthy practice guideline development using GRADE, so grading of recommendations, assessment, development, and evaluation approach. His research program also encompasses evaluation of population health outcomes using administrative data and pragmatic randomized trials in general internal medicine. So it's really my great pleasure to welcome Dr. Agarwal. Thank you.
Good morning, everyone. Thank you so much for having me. My name is Arnav Agarwal, and it's my pleasure to be here today. Today, I'm going to use type 2 diabetes and obesity as examples of a broader challenge in cardiometabolic medicine. We're generating more evidence than ever, but our processes of turning this into trustworthy guidance have not always kept pace. So the talk today focuses more broadly on opportunities to improve processes in how we synthesize evidence, how we translate relative effects into patient-specific absolute benefits and harms, and how we can keep guidelines current in areas where the evidence is rapidly evolving. I have no financial conflicts of interest to disclose. In terms of other relevant relationships, I'm a senior methodologist with a not-for-profit international organization called the Magic Evidence Ecosystem Foundation. Much of the work I'll be presenting here today is from Magic, and this organization focuses on trustworthy evidence synthesis and guideline development. I'm also the methods chairperson for ongoing BMJ rapid recommendations on diabetes and on obesity, which I'll be discussing in part today. And I'm a methodologist with Diabetes Canada Methods Committee, which has some overlap with the presentation today as well. So the objectives for today are simple. Number one, to describe why therapeutic decision-making in type 2 diabetes and obesity increasingly requires comparative, risk-stratified, and patient-centered evidence. And number two, to explain how living systematic reviews, network meta-analyses, and trustworthy guideline methods can help clinicians interpret rapidly evolving cardiometabolic evidence. So I want to start with a patient who should feel familiar to many of us. I have a 72-year-old man with type 2 diabetes for the past 12 years. His HbA1c is 7.1%. His eGFR is 42. He has some microalbuminuria with a urine ACR of 35. His history is significant for a prior NSTEMI. He's also had a previous admission in the past year for HFpEF, and his BMI is 34. His medications include metformin, glycoside, ramipril, and atorvastatin. So he asks you, doctor, my sugars are basically at target. Do I really need another diabetes medication? So for the folks in the room, I'll do a show of hands. What is your next step for this patient? Who would say they would make no change for this patient? Okay, no one in the room. Who would reduce the sulfonylurea as their next step? Okay, no one in the room. Who would add an SGLT2 inhibitor for the chronic kidney disease and HFpEF? Okay, half the room. Who would add a GLP-1 for atherosclerotic cardiovascular disease, obesity risk? Okay, 1/10 of the room. Who would consider both an SGLT2 and a GLP-1 upfront? Okay, quarter of the room. And who would consider finerenone here for CKD? Okay, the nephrologist in the room. Perfect. Excellent. So this is the clinical problem I wanted to highlight. A familiar diabetes decision is no longer simply a question of which medication lowers HbA1c. For this patient, glycemic control is only one part of that decision. We also need to think about kidney protection, heart failure prevention, atherosclerotic cardiovascular disease risk reduction, weight loss, hypoglycemia avoidance, cost, coverage, route of administration, and patient preferences. And this is where guidelines can become very difficult for us to use. Most guidelines acknowledge that these factors all matter, but clinicians still have to integrate all these factors at the bedside. So which outcomes matter most to patients? Which drug has the most evidence for those outcomes? And how large is the absolute benefit likely to be given a patient's baseline risk versus the absolute harms given a patient's baseline risk? So the problem is not simply that we need more evidence. In areas like diabetes, we have plenty of evidence. The harder problem is converting rapidly expanding multi-outcome evidence into recommendations that are current, comparative, risk stratified, and useful for real-world clinical decision-making. One major challenge in this space is just the sheer volume and complexity of evidence that we deal with. And this picture from a Nature Medicine article a few years ago is one of my favorites because it captures what I call the infodemic of evidence that we face in conditions like diabetes and obesity now. We have hundreds of randomized trials across many drug classes and many patient-important outcomes. But the challenge is not that there are not enough trials. The evidence is a lot, and it's also uneven. Some drugs have large cardiovascular outcome trials. Others have shorter trials focused on glycemia and weight loss. Some comparisons between drugs are direct, but many of these drugs have never been compared head-to-head for the outcomes that patients care about the most. That creates a big problem for traditional evidence models. Pairwise systematic reviews and individual randomized trials can answer narrow questions comparing drug A versus drug B or drug A versus placebo, but clinicians are usually choosing among many reasonable alternatives. Moreover, we have an issue with guidelines that fall behind the evidence. So in fast-moving areas, static guidelines can quickly become out of date. So the natural question to follow is, are our guidelines keeping pace? And I'll start by looking at existing Diabetes Canada guidelines in this space. To be clear, the intent of this is not to criticize any single professional society or any single guideline. It's more to reflect on where we are as an academic community with our guidelines. So the guideline makes recommendations for SGLT2 inhibitors and for GLP-1s with cardiovascular disease, chronic kidney disease, and heart failure, which are all in line with recent trial evidence. But there are some challenges here. On the right-hand side, I've summarized the narrative text that goes with the recommendation. And as you can see, it's just a bunch of narrative text. There's no sort of meta-analysis or pooling of trials that actually tells you how effective a medication is and how certain we are in the effects of that medication. It also just talks about trials that typically compare a treatment to standard of care. And so we don't actually have any sort of comparative evidence as to how an SGLT2 inhibitor compares to GLP-1 for patients with CKD, for example. Furthermore, this guideline is from 2024, and even though that's fairly recent, the evidence is already outdated. We have tirzepatide and other agents now, which have newer evidence and actually evidence of cardiovascular risk reduction. That isn't reflected in even the most recent guidelines we have. And then finally, we have a recommendation for CVD, we have a recommendation for CKD, but all patients with CVD and all patients with CKD are not the same. We have patients who are at lower risk of complications, and we have patients at higher risk of complications. So the meaning of a blanket recommendation for a drug across all patients with a certain condition is questionable. The other thing to highlight is in all comers, there's a recommendation for metformin. That's effectively a strong recommendation in favor for any patient who needs management to start on metformin. This is primarily because we have a comfort with using metformin. It has a reasonable side effect profile, and it's reasonably accessible from a cost perspective. Also because most of the trials that have compared these most recent new drugs use metformin as the backbone therapy. But in a space where we now have major medications like SGLT2s with major cardiorenal risk reduction, reasonable side effect profiles, is there a reasonable rationale to have a strong recommendation for first-line therapy for metformin for everyone? Questionable. KDIGO's latest 2026 guidelines, now out for public review for diabetic kidney disease, provides a useful contrast from a methods perspective, and they're stronger in a number of ways. Here, I provide a snapshot of the guidance and the evidence for SGLT2 inhibitors. So KDIGO has done independent systematic reviews and meta-analyses. They've taken those meta-analyses and they've constructed great summary findings tables, and they tell you SGLT2s have X relative effect. When you translate that the absolute effects for every 1,000 patients that take an SGLT2 inhibitor, the risk of dying is reduced by these many patients per 1,000 patients. And this is how confident or how certain we are in that evidence. So this is a step far ahead of just saying, here are the major trials we're aware of. But there's still challenges. First, here we have SGLT2s compared to standard care. So we don't know how effective SGLT2 inhibitors are compared to any other medication. Second, it's hard to interpret this table without more context. So cardiovascular risk reduction, a reduction in the risk of cardiovascular death of 7 fewer per 1,000. Is that an important reduction? Is that an unimportant reduction? If I offered a patient in front of me that a medication would reduce the risk of dying by 7 for every 1,000 patients that took a medication, would they consider that important or not? That's not very clear from the guideline or from the table. And then finally, when you look at this again, there's no way to actually understand if SGLT2 inhibitors should be recommended above or differently than any other medication. And in addition, this makes an all-encompassing analysis for all patients with CKD. So how does this compare for patients at the lowest risk of chronic kidney disease versus the highest risk of that spectrum with chronic kidney disease? Not clear from the evidence. So this brings us to guideline trustworthiness more broadly. How trustworthy are contemporary guidelines across the board? In 2011, the Institute of Medicine established 8 gold standard criteria for creating trustworthy clinical practice guidelines, and they're fairly intuitive. First, to have transparent processes and funding sources reported. Second, to report and effectively manage conflicts of interest. Third, to ensure that we have multidisciplinary, diverse panel representation, including patient partners. Fourth, that our guidelines are based on systematic reviews of the evidence. Fifth, that our recommendations are linked to that evidence. Sixth, that we have a clear strength and a clear direction when we make recommendations. Seventh, that we get external input as to how good our guidelines are before we publish them. And eighth, that we have a plan to keep them updated, to keep them up to date. A decade after Institute of Medicine trustworthiness standards are established, an analysis done last year shows that less than 20%, less than 1 in 5, adhere to these standards. So what does it take to make trustworthy guidelines for diabetes and obesity? There are 4 major components. First, we need credible treatment effects. That means evidence that reflects the latest available trials, includes the full range of patient-important outcomes, and incorporates clear decision thresholds that matter to patients, not just statistical significance. With this, we need a clear system like GRADE or other systems to make clear how confident or how certain we are in that evidence. It's one thing to say that medication A reduces the risk of stroke by 10%, but if all the studies were high risk of bias, if they all showed different findings and were inconsistent, if the confidence intervals around that 10% are extremely wide, that would change our interpretation of how much we want to rely on that evidence. Second, we need prognosis and risk stratification. The same relative treatment effect can mean something very different in a low-risk patient versus a high-risk patient. So we need to accurately identify a patient's baseline risk of cardiovascular and kidney complications before we can understand the absolute benefit that they are likely to have. Third, we need to account for the patient perspective, both in terms of the relative importance of outcomes and in terms of how they would weigh different treatment options and the benefits and harms associated with them. And fourth, we need a way to keep our guidelines living, to be up to date with the most recent evidence. Final methods concept before we dive in, and a key part of the evidence ecosystem, is the concept of in-network meta-analysis. Just by a show of hands, how many people are familiar with this concept? Okay, 2 hands, so I'll go over it. For those less familiar, a network meta-analysis allows us to compare multiple treatment alternatives at the same time. This matters because clinicians and patients are rarely choosing between a drug and placebo. They're often choosing between many different treatment options. A network meta-analysis can combine direct evidence, where 2 treatments were compared head-to-head, with indirect evidence, where treatments are connected through a common comparator. So by triangulating through a common drug that something is being compared to, you can estimate the effect of the drugs that have not been compared. This allows us to estimate comparative benefits and harms across many options, even when some head-to-head trials do not exist. It also helps us to move away from, does this drug work, to ask, how does this drug compare to other options across the outcomes that matter, by ranking medications based on their effect size and how confident or certain we are in that evidence. So before turning to diabetes, I will start with work that we did in the COVID-19 space that set the stage for this. COVID was the stress test for living evidence and living guidelines for obvious reasons. During the pandemic, evidence was incredibly rapidly evolving, and new trials were being published continuously. Clinicians, policymakers, and patients needed guidance that could keep up. And tasked with producing this up-to-date, trustworthy guideline, the World Health Organization partnered with our research team to create an evidence ecosystem combining iteratively updated evidence and linked guidelines addressing therapeutics for COVID-19. To do this, we produced a series of living systematic reviews and network meta-analyses, iteratively updated every few months to summarize the latest evidence. One of these reviews included over 400 trials and 166,000 patients over 5 iterations and provided the latest evidence on over 60 drugs. If you imagine an RCT, it's tough to design an RCT of 166,000 patients with 60 drugs. And this is why this kind of statistical analysis is important. Our work focused on risk stratifying patients with COVID-19, predicting their baseline risk of death and complications without treatment, and then estimating their likelihood of benefiting from these treatments by applying the relative effects of these treatments to that baseline risk. Moreover, our work focused on creating a standing process for this, a standing guideline panel, a standing evidence synthesis team, a standing panel of patient partners who could inform our guidelines. And finally, a standing partnership with a journal that was willing to partner in this case, which was the British Medical Journal, or the BMJ. This living evidence ecosystem supported 14 iterations of a WHO living guideline, its first ever living guideline, with risk-stratified recommendations on over 15 medications. The recommendations separated individuals with non-severe COVID from individuals with severe or critical COVID-19. The guideline had significant uptake, especially across WHO member states who didn't have previous guidelines and adapted or adopted these as their formal national guidelines. The lesson for us here was that evidence changes quickly, and it is possible to create a standing process where systematic reviews and risk-stratified guideline recommendations can keep up. Now, the next question was, can we do the same thing outside a pandemic? Partnering across 3 research teams, our next challenge was diabetes. To create a living evidence ecosystem in diabetes, our team led and coordinated 3 sets of living systematic reviews that formed the foundation for a living guideline. First, a living review of prognostic models to risk stratify patients with diabetes based on their cardiovascular and kidney risk, which identified 13 prognostic models. Second, a living systematic review and network meta-analysis evaluating available treatments with 869 trials and nearly 500,000 participants. That's all the trials we have in the space of diabetes. And third, a living review on patient values and preferences pertaining to existing and emerging drugs for type 2 diabetes, with 30 studies and over 12,000 participants. We then recruited a standing multidisciplinary panel of unconflicted clinical experts, patient partners, and methodologists with international representation. The panel included cardiologists, nephrologists, endocrinologists, general practitioners, and general internists. This slide shows the treatment effects component of that evidence ecosystem. The systematic review and network meta-analysis of treatment effects encompassed 869 trials, almost 500,000 patients, 13 drug classes, and 26 patient-important outcomes. On the left-hand side is the network plot, which shows which drug classes have been directly compared. The nodes represent drug classes, and the lines represent direct trial comparisons. An important point here is that while the evidence network is large and dense, it is not evenly distributed. Some comparisons are common, for example, SGLT2s versus standard care, DPP4s versus standard care, GLP-1s versus standard care. And some treatment comparisons are uncommon, like any of those drugs compared to one another, which is really the decision that we face on a daily basis. So the findings of the last iteration of our network meta-analysis are presented here, and there's a lot to digest. This is the totality of evidence effectively for type 2 diabetes randomized trials. So I'll break down the main highlights here, and this is available online in case others are interested in taking a deeper dive. The headline finding was that SGLT2 inhibitors and GLP-1s have the strongest and most consistent evidence for cardiovascular and kidney benefits. Both reduce all-cause death, cardiovascular death, non-fatal myocardial infarction, and major adverse cardiac events with high certainty. Second, however, the outcomes profiles differ in clinically important ways. SGLT2 inhibitors reduce hospitalization for heart failure and kidney disease progression to a greater extent, whereas GLP-1s reduce non-fatal stroke and offer larger body weight reduction to a greater extent. Third, for adults with chronic kidney disease, finerenone reduces death, kidney disease progression, and heart failure hospitalization, but with the important trade-off of a 6-fold increase in the risk of hypokalemia. And fourth, tirzepatide has the largest weight loss effect among prioritized diabetes medications, but we had very low certainty at the time of this evidence cut, which was July 2025. In the span of less than 1 year, we now have moderate to high certainty evidence that tirzepatide, in fact, does reduce major cardiac adverse events similar to other GLP-1s. So again, a rapidly evolving space, but a large amount of evidence to synthesize and stay on top of. Now, I said the last slide captures all the totality of evidence in randomized trials, and that's almost true, except weight loss and HbA1c effects, which are presented here. And again, lots of data to digest, but I'll highlight the key takeaways. The first is that tirzepatide demonstrates the most robust weight and A1C lowering effects with moderate to high certainty. The second, the next largest effects are for a medication called orforglipron, but this only has low certainty evidence at the moment. Interestingly, this medication will be a major player because it was recently FDA approved as of a couple of months ago. So again, new and emerging medications taking the center stage in both the diabetes and the obesity space. Third, recognizing that clinically relevant variation exists across GLP-1s, we looked at the effects of each GLP-1 separately rather than looking at a class effect for weight loss and A1C. And we did see that there were major differences in terms of A1C reduction and weight loss reduction across the different GLP-1s, reassuringly the most robust with subcutaneous semaglutide. And then fourth, like we raised with the Diabetes Canada guidelines in the beginning, tirzepatide, GLP-1s, SGLT2s all outperform metformin for weight loss, and they all either compare or outperform metformin for A1C risk reduction. Again, raising the question, are our current guidelines really supported by the latest available evidence? Whenever we pool these large bodies of data across heterogeneous populations, we wonder, do the effects differ in any way based on patient characteristics? And we use subgroup analyses or more fancy meta-regression to evaluate whether baseline patient characteristics modify the effects of treatments on patient-important outcomes. So our systematic review evaluated this, and we looked at 4 patient characteristics to say, do outcomes differ based on these 4 characteristics? The 4 were the proportion of patients in trials with established cardiovascular disease, the mean baseline GFR, the mean baseline body mass index, and the duration of follow-up. How long were patients followed in a trial? Despite us thinking that all our patients with diabetes have different benefits in relative terms from these treatments, we found no evidence of any subgroup effects based on any of these factors. So all comers with diabetes stand to benefit in relative terms equally from these medications. They all have the same relative effects for these patients. But as we spoke earlier, patients and clinicians are most interested in absolute treatment effects. What does a given treatment do for the patient sitting in front of you in clinic? When we tell a patient that medication A reduces the risk of stroke by 10%, the next natural question is, what is this patient's risk of stroke without treatment? And what does the medication do for that specific patient? The figure on the right exemplifies the same concept. Here, the relative effect of the treatment is the same in all three cases. It's a relative risk of 0.67 or a relative risk reduction of 33% in the risk of an outcome occurring. In the high-risk population, which is population 1 here, this translates to a reduction from 30% absolute risk without treatment to 20% with treatment. That's a 10% reduction in the absolute risk of an outcome. In the low-risk population, this translates to a reduction from 2% or from 3% to 2%, which is a 1% absolute risk reduction. So same relative risk, but in two different populations with two different risk profiles, you have a 10% absolute risk reduction versus a 1% absolute risk reduction. And that may well translate to different decisions for what patients want with a treatment. So how can we translate this concept to diabetes? Tough. But to produce risk stratified absolute effect estimates, we tried to develop a clear risk stratification approach and then establish baseline risk of events occurring for each risk group. So first we considered risk in broader buckets: those without established cardiovascular or kidney disease, those with established cardiovascular or kidney disease. Among those without established cardiovascular disease or kidney disease, there are individuals with few or no risk factors who are at lower risk of complications, and there's individuals with hypertension, dyslipidemia, elevated BMI with a much higher risk of complications. Similarly, the risk varies in individuals with established disease. Among those individuals, there's overlap between cardiovascular disease and kidney disease, and there's individuals at lower risk of complications and individuals at higher risk of complications. Our second consideration was how many risk groups to define, because as you can imagine, we can technically define a countless number of risk groups in diabetes. But in order to be useful for clinicians, you're going to need to balance rigor with practicality. No clinician is picking up a guideline and saying, which of these 50 risk groups does my patient fit into? And so to keep this as pragmatic as possible, we chose to define three major risk groups: individuals at lower risk, moderate risk, or higher risk of cardiovascular and kidney complications. And third, we found 12 or 13 different prognostic models, but no prognostic model actually covered all the patient-important outcomes that matter to patients with diabetes. And so we chose to map out the different prognostic models we had across the different outcomes and then triangulate to reach the best estimates for baseline risk of these events occurring without treatment. So what does that look like in a guideline? This is from the 2025 first iteration of the guideline published in the BMJ. And as you can see, we defined three risk groups here: lower risk individuals, which were individuals with 3 or fewer cardiovascular risk factors and no evidence of established disease; moderate risk individuals, which were people with more than 3 risk factors or with established cardiovascular or kidney disease at the lower risk of that spectrum; and then individuals at higher risk, which were individuals with established cardiovascular and kidney disease with higher risk of complications or with established heart failure, where the risk of recurrent heart failure admissions or other complications was naturally higher. Now, as we anticipated, the same relative treatment effects produce vastly different absolute effects for individuals in the lower risk group compared to the higher risk group. On the lower risk side, absolute risk of complications without treatment and the absolute effects on cardiovascular and kidney benefits are smaller. That does not mean that the drugs don't work biologically. It just means that when the baseline risk is low, there are fewer events that you have to prevent. So for lower risk adults with diabetes, SGLT2 inhibitors reduce the risk of death by 0.2% and GLP-1s by 0.3% respectively. And that's over a 5-year time period. If I present those effects to the majority of patients in the lower risk group, I suspect many patients would be disinclined from taking the treatment if I said your risk of death is going to be reduced by 0.2% over the next 5 years, but your risk of genital infections and euglycemic DKA and other complications is substantially higher. On the higher risk side, the absolute risks of complications without treatment and the absolute effects on benefits becomes much larger. So for patients with established cardiovascular and kidney disease at higher risk, SGLT2 inhibitors produce a 2.3% reduced risk of death, and GLP-1s a 2.4% reduced risk of death. Now, from studies that have been done with patients, most or all patients would think that a 2% reduction in my risk of dying is worth taking a medication for. So this really highlights how absolute effects can change patient decisions and we shouldn't focus only on relative effects. So what does this look like in terms of trustworthy guidelines? Bringing together credible risk stratification, patient values, and credible evidence summaries that I just presented, we produced the first iteration of the Living Guideline last year, published in the BMJ. We're currently now working on a second iteration, and I'm proud and excited to say that we have increased representation from U of A faculty, which is always wonderful. So here for high-risk patients, particularly those with established cardiovascular and kidney disease, the absolute benefits of SGLT2s, GLP-1s, finerenone are larger, and the guideline therefore makes recommendations in favor of these therapies in higher risk groups. For moderate risk and lower risk groups, the absolute benefits are less pronounced. Decisions are therefore more preference sensitive, and recommendations move to weak recommendations in favor, or in that lowest risk group, we make weak recommendations against SGLT2s and GLP-1s, because a 0.2% risk reduction in the risk of dying is not something that most patients consider as important. So this clearly represents a lot of work. Does it address all the problems ever in evidence synthesis and guidelines? And the answer is no, because many of you may not have been familiar with that guideline despite it being published in the BMJ. And the reason is we as clinicians rely on our professional society guidelines. So making trustworthy guidelines is critical, but their impact is only as much as their uptake. And so that's one challenge with this. A second challenge is that clinicians may have difficulty actually placing their patient in a risk group. So there's no publicly available prognostic model for me as a general internist to turn to say, is my patient moderate risk or higher risk? It's a clinical judgment, and you can see that judgment can impact patient decisions quite largely. I'll also say the risk groups are large. When you pick 3 risk groups to represent all of diabetes, you start to encompass very heterogeneous patients within a certain risk bucket. And so the guideline isn't perfect, but again, it's a balance between practicality and rigor. Third, class-specific effects versus drug-specific effects. When I'm on the ward, people have debates around, should I prescribe X medication in a certain class or Y medication in a certain class? This work isn't designed to answer that question outside of maybe GLP-1s for A1C and weight loss. And that's a limitation. But again, there's a balance between parsing out things so finely that you can't actually pool evidence versus combining evidence that you think is poolable. And then fourth, a clinician, when we published this guideline, tweeted to me and said, Arnav, should I prescribe no medication to my low-risk patient for diabetes? Are you just saying nothing works and they should be on absolutely nothing? And the answer is, well, the guideline scope is important. So the guideline scope is cardiovascular risk reduction and kidney risk reduction. It doesn't mean that patients don't have any indication for medication. So it's part of this is acknowledging that patients can have multiple indications for treatments. And this guideline is not an all answer to all patients with diabetes and indications for management. Now, the next obvious question is, once you've done this large network meta-analysis and guideline, do we really need a living model? And the answer is yes. I won't spend too much time on this slide, but just to say, since July 31st, 2025, which was the time of our evidence cut, there have been 3 New England papers and a Lancet paper that are practice changing. Tirzepatide, non-inferior to GLP-1s in type 2 diabetes with atherosclerotic cardiovascular disease, surpassed CVOT. The SOUL trial, oral semaglutide reduced MACE in high-risk type 2 diabetes. The STRIDE trial, published in Lancet, semaglutide in peripheral arterial disease with type 2 diabetes. Confidence, finerenone and empagliflozin combined have a larger effect in albuminuria risk reduction for CKD. So practice-changing evidence, our work as of July 2025, already out of date. We need a way to keep on top of this evidence, and that's why we need living frameworks. Now, I'm just going to do a quick time check. Okay, I'm at 35. In my last few minutes, I'll focus on obesity. Now, obesity pharmacotherapy is entering a similar evidence arena as type 2 diabetes, and perhaps even faster. We now have highly effective medications, expanding cardiovascular outcome evidence, and several newer agents that are either recently studied or still emerging. This creates a lot of clinical opportunity and excitement, but it also creates complexity. The clinical question can't just be limited to how much weight someone loses. Instead, we need to understand the effects on cardiovascular and kidney outcomes, quality of life, function, and treatment burdens. So this slide shows what it would really take to build obesity guidance that goes beyond weight loss alone. Patients and clinicians care about all these other outcomes. And in particular, we need to think about the risks that come with these medications in addition to the weight loss benefits. So when we talk about weight loss, we lose fat mass, but we also lose lean mass. And in our high-risk, older, sarcopenic, high-risk patients, that risk isn't benign. And so balancing these different benefits and harms becomes increasingly important. When we look at evidence and guidelines, there's also the issue of conflicts of interest. And I can tell you from trying to recruit a panel for our international obesity guideline, it's hard to find expert and not receiving financial incentives in this space. And so the commercial stakes in obesity pharmacotherapy are enormous. And that means that trustworthy guidelines need a careful process for conflict of interest management, transparent evidence synthesis, and meaningful patient input, again, without conflict. Finally, to be useful, guidelines need to consider cardio, kidney, metabolic risk stratification, just as we did in diabetes. They also need to consider what happens when people discontinue these medications, because effects tend to reverse and these medications are not benign or inexpensive. So how do we put all this together? We've now produced the most comprehensive available network meta-analysis to date, summarizing effects on all pharmacotherapies for overweight and obesity. This is currently in press in the BMJ and should be out by the end of June. And this encompasses 260 trials, 99,000 patients, and close to 20 medications. So again, no randomized trial that can possibly realistically financially accomplish that in a single go. The next step is to move from this evidence to trustworthy guideline recommendations. To accomplish this, we're going to take a similar approach to type 2 diabetes. Here I summarize all the major findings across trials captured in this review in a single table. This time I think it is a single table. I suspect it is impossible to digest all of it from where you are, so I'll highlight the main findings here. First, tirzepatide and cagrilintide semaglutide are among the most effective for body weight reduction from baseline, producing approximately 15% reduction from baseline on average. Oral and subcutaneous semaglutide were among the intermediately effective. Second, tirzepatide is among the most effective in reducing fat mass by over 25% reduction from baseline. Unfortunately, it is also among the most harmful in reducing lean mass by over 8% from baseline. Third, and not entirely captured here, subcutaneous semaglutide is the only medication that has proven trial evidence for reducing the risk of all-cause death and myocardial infarction. And this may change quickly now, given that we have cardiovascular outcome trials emerging. And fourth, newer medications that I will have a tough time pronouncing, but retatrutide, ecnoglutide, mazdutide, and orforglipron, all supported by low certainty evidence, also have massive effects in terms of body weight reduction, ranging from 12% to 18% from baseline. Finally, CagriSema, tirzepatide, and GLP-1s remain among the worst in terms of increasing gastrointestinal events and gallbladder-related disorders. So again, the medications with the strongest benefits also paired with the largest side effect profiles. What about accounting for what happens when individuals stop GLP-1s? Discontinuation effects are increasingly important in this space for guidelines. We've now conducted 3 systematic reviews to address this question. One looking at randomized trials that track outcomes post-discontinuation, one looking at single-arm studies that looked at the same, and a third looking at single-arm studies that address the effect of switching to an anti-obesity medication other than GLP-1s. What we found in broad terms is that participants are likely to regain a substantial proportion of their initial weight within a year, up to 50%, though the evidence is not robust and estimates regarding how much weight gain they experience is really quite variable across the studies. But we can say all the evidence is consistent in pointing to a signal of significant weight regain, in addition to the adverse effect profiles of these medications. Now, do we need international guidelines addressing this space? Absolutely. Similar to type 2 diabetes, our current national guidelines do not synthesize all the available evidence using a meta-analysis. They don't rate how confident or certain they are in that evidence using a system like GRADE. They don't compare treatments to one another using any sort of statistical method like network meta-analysis. And as shown on the slide, interestingly, they take a complication-centric approach. So Obesity Canada guidelines say we recommend the following for prediabetes and obesity. We recommend the following for diabetes and obesity. We recommend the following for OSA and obesity, which is fair because those are different subpopulations of obesity, but the relative effects of those treatments, like we saw in diabetes, don't actually vary. So do we really believe that we need different recommendations for prediabetes and diabetes in terms of which medications work? Do we need to look at those effects separately, or can we get more from combining those studies together? So we have an opportunity now to improve these standards, and we're at the early stages of developing trustworthy international guidelines for adults with overweight and obesity. The opportunities are an unconflicted panel, pooling evidence across subpopulations rather than separating them out, using network meta-analyses to compare multiple medication options, having risk stratification, because again, obesity and diabetes, you have people at lower risk and people at higher risk. These people aren't just one bucket. So we need to look at the effects of those treatments separately and make risk stratified recommendations. And what do the absolute treatment effects look like? If I'm sitting with a patient, they would probably find it much more useful for me to say, this would reduce your risk of dying in the next 5 years by 2%, than me saying, this leads to a 33% relative risk reduction compared to placebo. How do we get to that evidence? So I'll end with where to next from a sustainability perspective. This body of work, as I said, is only as good as people who pick up the guideline and use it, but it also serves as a prototype from a methods perspective for trustworthy evidence ecosystems and guideline development. But this effort on its own isn't enough because Diabetes Canada, Obesity Canada, all the other guidelines we have aren't magically changing their processes. So clinicians and patients primarily continue to rely on local and national professional societies for guidelines. And the BMJ Rapid Recommendation Series that I co-lead is capacity limited. So we've done 20 guidelines in the span of 10 years, but we're covering all of medicine, all of surgery, all of primary care. And there's no possible way we can address all topics ever. And so this is a high resource, time intensive setup, but professional societies need to start moving to models that are more trustworthy. Now, the ideal solution is a global evidence local implementation solution. So we establish evidence ecosystems as collaborative networks that are international. You leverage the expertise of methodologists who do this professionally, and then professional societies can make local guidelines relying on globally synthesized evidence. Instead of each organization, Diabetes Canada, Diabetes Mexico, making their own separate guidelines and their own evidence syntheses, having a combined effort. This would lead to less duplication of efforts and more pooled resource utilization. But a parallel solution, and maybe the stopgap solution in the meantime, is to build local capacity. And one of the focuses of my research program is to support professional societies in Canada to move towards methods that are more trustworthy. So 2 examples on the slide. Diabetes Canada has recently adopted the GREAT approach to move to a process that is more trustworthy in terms of synthesizing evidence using meta-analyses and producing trustworthy guidelines. And the Canadian Rheumatology Association has launched its first living guideline, or one of its first living guidelines in a series of living guidelines addressing pharmacological management for RA, now in its 4th iteration. So for this to be successful at scale, I can tell you we don't have enough funding. And really the key is professional societies need to invest more in trustworthy evidence synthesis and guidelines, and methodologists need to create workshops and shops that can actually produce and support these guidelines at scale. My closing thoughts. First, rigorous evidence synthesis and risk stratified trustworthy guidelines are critical for decision making. Just general relative effect estimates from a single trial, not a great way to inform our clinical decisions. Second, living models for evidence and guidelines are critical, particularly in fast-moving areas like diabetes and obesity. Third, these evidence ecosystems are great, but they're expensive and time-intensive and resource-intensive. They require a lot of funding. And fourth, with that, we need investment in global evidence collaboratives to mitigate duplicative efforts and instead to pool resources so that guidelines can leverage the same evidence base to make their decisions. And I'll end with that. Thank you.
Okay, so with that, we'll open it up for questions, but I'll start first just to sort of close the loop. how would you change the medication for that first patient that you got everyone to?
I have a hidden slide. I don't know how to bring it up, but so I'll ask the room. I mean, would anyone change their answer in terms of their next step for that patient?
I want to get them off the sulfonylurea gradually, get on either an SGLT2 or GLP-1 based on the patient preference.
Okay, yeah, totally fair. So Vijay says he would stop the sulfonylurea, he'd switch gradually to an SGLT2 or a GLP-1. That's fair, but I'll just say the room was split and no one picked reduce the sulfonylurea in the first round. So again, I think the answer I would give is I would ask a patient what their priority really is. And I would also look at their risk profile. If this patient has had 5 strokes, starting on a GLP-1 is more priority. If they've had 3 admissions for HFpEF in the past year, starting them on an SGLT2 inhibitor is a larger priority because the risk reduction is larger with an SGLT2 for that risk profile. So in the given patient I presented, I think all options except do nothing are a reasonable option because I don't think changing nothing for that patient is beneficial. You at least have a sulfonylurea with very little cardiorenal risk protection and better medication alternatives there. But I don't, again, guidelines don't solve all the answers. Are all the questions. Thank you.
Yeah.
Peter.
Could you comment on finerenone causing hyperglycemia?
Finerenone causing hyperglycemia. Okay. I don't know if that's captured in our on the summary slide, so I'd actually have to look back. It's a great question.
I didn't know that.
The major signal we saw with finerenone across trials was with hyperkalemia risk, with a 6-fold increase in that risk. I'm not directly familiar with the hyperglycemia risk from a trial perspective in terms of that evidence, but it's possible that I just don't know that, and it is captured in the network meta-analysis. So I can have a look, Peter, and get back to you.
Maybe I misheard because I thought that you said that finerenone was.
Oh no, I meant hyperkalemia. Sorry, maybe I misspoke.
This is my poor eyesight. Sorry.
I'll pull the slide back up. But yeah, with finerenone here, you have a 6-fold or almost 6-fold of relative risk increase of 5.92.
In fact, that green box, severe hypoglycemia.
Yeah.
That column, the only. Oh, it's protective.
It's protective. It's protective. Yeah. So it does have a glycemic reduction effect here of 36%. But again, with confidence intervals that are decently wide, all on the side of benefit, but decently wide.
Oh, okay.
Yeah.
Thank you.
And possibly changed with the latest trials that are out there now for finerenone as well.
Yes.
Thanks. Great presentation, Arnav, and great work that you're doing. And we know, there are so little conditions where there is good evidence and we fall apart with implementation, right? And so I wonder if you have any thoughts in terms of implementation science at the local level. I mean, those constant pop-ups on Connect Care are nothing but frustrating. I don't think they work. And, there are other ways to sort of have an impact. And so number one, I wondered about some thoughts that you might have in terms of local implementation. You talked about specialty societies, but I'm not even so sure that that's the level. I think we need to be more local than that. And then my second question was, I was happy to see the patient partners that you had on your guideline committees, because in a lot of situations, we have patients coming into Emerge, but they're so happy on their, just recently I had somebody on warfarin who didn't want to switch to a DOAC, so happy with their metformin because, they've been on it for, and so, I think that's an important consideration as well. And I wondered if there were any learnings from your, the involving the patient partners.
Yeah, thanks, Armin. So I completely agree. I think the space for local implementation efforts on these guidelines is equally critical as producing trustworthy guidelines. I can say we haven't done this directly with diabetes or with obesity, but with a group of researchers here within the Department of Medicine, we're working, for example, in the primary care space on developing an AI-based model that can integrate into primary care that takes a trustworthy guideline, chooses 5 recommendations, and has like targeted pop-ups to identify this patient has had 4 admissions for HFpEF. Are they on an SGLT2 inhibitor? Can you generate a prescription for an SGLT2 inhibitor through the EMR system? And so that process requires choosing a trustworthy guideline and then taking it forward to a local implementation step through an EMR system. The group I referenced in the beginning, the Magic Evidence Ecosystem Foundation, produces these guidelines not only in journals, but it also produces it through an electronic platform that can actually link into EMRs. So in several European countries, there have been efforts to actually integrate a recommendation directly into the EMR through the guideline directly. And so that is ideally where we get to. We have guidelines that can directly link to EMR systems that can directly inform clinical encounters. We're not there yet in terms of structures here, but I think projects like that AI-based primary care implementation model are a step forward in that direction. And I think AI has great potential in that space.
I think there's capacity within Epic, but I think we just haven't used it, like or opened it up or, enabled it, I guess.
Yeah, absolutely. And I come from Ontario where we have a different Epic system up the mountain in Hamilton and down the mountain in the same city. So being in a province where we have a unified Connect Care Epic system makes it so much easier to develop implementation strategies like that. So absolutely, I think it's a fertile grounds for exploration. To your question about patient partners, it's always interesting to hear how divergent the clinical expert inputs are sometimes from what you get from patient partners, because you would think that patients would really value a reduction in the risk of major adverse cardiac events, but some patients really just don't want to be on injections, or they prefer a once weekly injection to a once daily pill. And those are decisions that we may, as clinicians, think we have a good understanding of, but we really don't have as good an understanding as the average patient living with this condition day in and day out. And so I learned a lot in this process from working with the patient partners. And, in this case, we had only 2 for the diabetes guideline, but for the obesity guideline, we're looking to expand that to almost like a panel of 6 to 10, because we also recognize that patient partners are so divergent in their own experiences. And so if you're trying to make a guideline for an average patient from the patient perspective, you need more than 2 individuals who represent that perspective. Yeah. Thank you.
Yeah, I had 2 questions. They might be a little off topic. Can you put a later slide where you had all the GLP-1s? That was comparing the weight loss or lean body mass. That way it was later towards the end.
Yes, for obesity.
Questions more on, at the end of the day, we are limited by what the trials chose to study. And I'm juxtaposing your work, which is fantastic, with Evangelist's work in sort of anti-aging, because when I looked at this, the only thing is methanol. That actually is good. That's also because it's been around forever. So my first comment is, are we actually including all the outcomes? Because there isn't money to do the 50-year trial.
Yeah.
The second one is, it's the next slide, I think, is I was shocked to see that oral semaglutide had a greater reduction, not really statistically in body weight, but was actually better for lean mass. I was under the impression it was not a well-tolerated drug that didn't work well. So 2 different questions. Maybe comment on that.
Yeah, that's an excellent question. So I'll answer them separately, and I'll say most of the trials that were included in our diabetes work as well as the obesity work have short follow-ups. They're follow-ups that are limited to 6 months to 1 year. I think the median follow-up was 1 year. And so how do we estimate outcomes over a 5-year period, which is what patients care about, is a challenge. We did this statistically by modeling what a risk looks like over a 5-year period and using a baseline risk of events occurring without treatment over a 5-year window. But it's not perfect because risk isn't linear over 5 years and it's hard to estimate that. So that's a general limitation. Any of this work, unfortunately, is only as good as the trials, right? And if the trials are high risk of bias or they have short follow-ups, unfortunately, this will reflect the same. It's a great point regarding oral semaglutide and lean body mass. I don't have a good explanation for that. My suspicion is, despite not being low or very low certainty, oral semaglutide is informed by much fewer trials. And so you have generally less precise and less certain estimates, despite the confidence intervals not reflecting that uncertainty. The number of participants and the number of trials that inform like subcutaneous semaglutide, for example, are far more. And so this is, in addition to precision, you also probably have a bit of an effect of regression towards the mean as you start to accumulate that evidence across trials. So that might change. And again, in obesity, we don't have, unfortunately, the resources to set this up as a living guideline or a living network meta-analysis. And this space has evolved since I probably put together these slides last week. So, if we do an update on this in a year from now, a lot of these estimates might look very different, and a lot of the drugs on this list might also look very different. Thanks, Vijay.
Okay, with that then, if there's no further questions, I'd like to thank Arnav again for such a great talk, and please reach out to him if you want collaborations, questions, anything like that. We're really here trying to support our new faculty, and so I think you're off to a great start. So congratulations, and thank you everyone, and that'll close the session for today. Great.
Thank you.